Oh, hi friends. So I'll be giving a little clinical snippet on one of the case that we have had on small bowel obstruction and the new drug that we used. I'm sure many of you would have heard this prucalopride. So the point in discussion is not about usage of this particular drug, but whether this drug was useful in this particular case or had this to be used with any other combination. So we'll just reason it out and what is the evidence or data available, because this was a clinical problem, and and we'll just go through what we really had to do to fix this. So this was a 73-year-old gentleman. Um, so this was a 73-year-old gentleman with a past medical history of focal dystonia and right hemiparesis. So this gentleman, he's a veterinary doctor, so who had a focal dystonia with right-sided hemiparesis, and he had a weak cough. And this gentleman basically came with the small bowel obstruction, and he aspirated during OGD, went into respiratory failure, needed intubation and mechanical ventilation. So this was the sort of a clinical context that he came with. So, so you have to look at him as a elderly guy with a progressive neurodegenerative problem of some order, with small bowel obstruction, with aspiration during endoscopy, landing upon ventilator. So that was the situation. And when he came to ICU intubated, his abdomen was hugely distended, and he had abdominal compartment syndrome because he went into respiratory failure, he had wheeze, and his abdominal pressures were sitting at 20, and he had acute kidney injury. So this was a typical conundrum that he came. And if you see his X-ray, friends, I think there's a huge small bowel dilatation, and abdomen was quite firm and distended. Okay, so that's his background. And this is a CT. So I'll just show you his CT, which we did. So where there is a lot of bowel distension that was there. So obviously in this situation, it's a sort of a pseudo obstruction or an ileus, you can call it. So you would give prokinetics to fix this. So gastroenterologists were involved. And in this particular patient, so they suggested prokinetic. Okay, so this is a new prokinetic drug. So you see he's aspirated, and I think you saw all the bowel distensions. We'll see all the bowel distensions soon. So that was the bibasal sort of a opacities that he had. And you'll slowly see a lot of bowel distension that are there. So you can see a lot of bowel distension. You can see the bowels are hugely dilated, small bowels. So basically the report was the whole jejunum and ileal loops and duodenal, everything was dilated. So you can see the huge dilated loops. With abdominal compartment syndrome on a ventilator, veterinary doctor with a weak cough, right hemiparesis, and a focal dystonia. So the question is what prokinetic we would use. So the thought at that point of time was metoclopramide having issues, and he was on antipsychotic medications with an issue of having extrapyramidal symptoms. So gastroenterologists felt that we use proculapride. So for all our intensive care colleagues, we'll just deliberate on what is proculapride and whether was it really useful in this particular patient and what is its mechanism. So it's important, my friends, that the positioning of these drugs and the underlying pathology sometimes has a bearing on the recovery process, because that's when it dawned upon me that we should look into prokilopride, whether it really has a role in good small bowel motility, because here it was mainly small bowel ileus. It was not a colonic ileus. So that is where we looked into literature, and that is where this makes it interesting, this snippet. And so now the question is there a role for oral prokilopride with IV metoclopramide? That was a question that came to me, and I discussed with all my team whether this combination, because the gastroenterologist said don't use metoclopramide because of extrapyramidal, but that we will take care. We are intensivists, we can look after extrapyramidal. He's on ventilator, that's least of my concern. But abdomen remains distended, and there was absolutely no change with prokilopride. There was really no major difference. He didn't pass bladders, there was no bowel sounds. So what is prokilopride? So this is the lumen of the intestine. So there are a lot of serotonin produced in the sort of the mucosal cells or the intestinal wall. And prokilopride is a 5-HT4 receptors which are present. So it is a agonist. So it acts on this 5-HT, 5-hydroxytryptophan 4 receptors, and it facilitates the action of serotonin on this, and it facilitates the GI motility. So mainly these 5-HT4 receptors, if you look into the literature, are predominantly present in the colon. and their presence in the small bowel is not as significant as it is present in colon. So predominant action of prokilopride, even if you look into literature, is more for colonic movement. But this is a patient who had a small bowel ileus, and that is where our thought came, whether this is really helping. And we look into whether there is an evidence of one superiority over another. So, and as I said, mainly prokilopride helps in colonic movement and motility of the colon. So this was the mechanism of action. So on the contrary, let us review the mechanism of metoclopramide. So metoclopramide has a very interesting action. I'm sure you all have read this during pharmacology, but just to reiterate, given this clinical context, so it is a dopamine D2 antagonist. So metoclopramide acts on the 5-HT3 receptors and D2, which are predominantly present in the, it acts at the central level and at the local level, which are mainly present in the small bowel. And it has an antagonistic effect on the D2 and 5-HT3. And it also has agonistic effects of 5-HT2, which means metoclopramide has a bimodal function. It has effect on the small bowel to a large extent and on little bit on the large bowel, predominantly on the stomach and the small bowel. And it has another unique action. So it is a D2 antagonist, 5-HT3 receptors antagonist and 5-HT4 receptor antagonist. And interestingly, the apomorphine basically acts on the GI system, and it causes the lower esophageal sphincter relaxation, and it apomorphine inhibits the peristaltic movements of the small bowel. So metoclopramide blocks the action of apomorphine and it increases the tone of the lower esophageal sphincter. It facilitates duodenal sort of a contractility and duodenal sort of a peristalsis is what duodenal and jejunal sort of a peristalsis it also facilitates. So if you look at the overall functionality, so metoclopramide seems to have a more potent action on the small bowel and on the stomach and also on the colon. So the question we had was, should we combine both? So we did discuss with gastroenterologists trying to reason out the same thing, that proculapride, which we are using, predominantly acts on the colon. So why don't we combine with metoclopramide? And extrapyramidal will take care of it with whatever other drugs that we may have to use if it manifests. And we used metoclopramide. And guess what happened? He used metoclopramide with procalamide. He opens the bowel, intra-abdominal pressure comes down from 20 to 10, and abdominal distension significantly settles down. And today, as I'm giving this talk, we have extubated him and he's doing fine. Otherwise, we were really worried whether we couldn't be extubated. So this is just a case in example where you have to apply knowledge, because possibly, I don't know, perhaps maybe had you stuck to just giving prokilopride, it may have ultimately resolved, but possibly it may have taken much longer time for this ileus to settle down. But I would still believe that metoclopramide is possibly the drug of choice when there is more of stomach and small bowel ileus that is predominant. But if it is colonic, yes, prokilopride definitely seems to have. But then we started looking into the evidence. There's not much studies comparing head on head with prokilopride with metoclopramide. There's only one study which came in 2024. Really considering that prokilopride is a newer drug, we understand that. So this was a study which came from Egyptian authors. Comparison of enteral prokilopride versus, because prokilopride, it is available only as enteral, 2 milligram twice a day we give, versus intravenous metoclopramide for feed intolerance in patients with critical, a randomized double-blind blinded study. This was an Egyptian study. So here they looked at the two arms, around 70 patients they took. So one arm contained prokilopride, 2 mg per day, metoclopramide 10 mg 6 to 8 hourly. They looked at day 7. This was a positive study favoring prokilopride. Day 7 gastric residual volume, if you see, it was significantly less in prokilopride as compared to metoclopramide. And percentage of gastric residual volume reduction also was more in prokilopride. And because there was a better feed tolerance, calorie intake also had a higher success with prokilopride, and safety also, there was no event. So this study sort of tends to say that prokilopride is as good or even better than metoclopramide for facilitating feed tolerance. This is something for nutritionists or dietitians to make a note that you can keep this as a drug in your armamentarium to facilitate and enhance our feed tolerance. So this is all the data that we have on prokilopride and metoclopramide. So this is just a clinical snippet as to how we even combination, because when you look at the literature for the combination, there's no data. to say whether combination, but there is a suggestion that in refractory ileus, combination has to be considered. So there is a reference that combination of prokilopride with metoclopramide. So maybe cases like this, where there's predominantly gastric and small bowel ileus, perhaps maybe we may have to use metoclopramide along with prokilopride. Of course, keeping in mind the risks of these prokinetics, because they can cause QT prolongation and they can cause CNS toxicity like ataxia and extrapyramidal symptoms. You have to keep an eye on that. But we may have to use this in a refractory cases like our case to save a life and get him out of the ventilator soon. Otherwise, he would have, it would have been more protracted and it would have led to other secondary organ damage. So this patient's AKI improved, his respiratory PF ratio significant. He was on FI to 60% when we started. So we have extubated now. He's doing well, and his AKI also is nicely settled, and abdominal pressures also is nicely settled. He's opened the flatters. I can hear good bowel sounds. So just this is a case in example to keep these knowledge points in your practice when you come across these bowel obstructions, especially in elderly patients with progressive neurodegenerative condition. So request you all to submit your valuable work to Journal of Acute Care. Of course, you can visit my website to read to this lecture. Thank you. Thank you very much.